Well, hello. Big shout out to everyone attending the Going Digital Behavioral Health Tech Symposium. And I'm delighted to be joined by an expert here in the field of behavioral health. This conversation is all about connecting to the community and really talking about behavioral health in an integrative care environment. My name is Eric Meyer, Chief Executive Officer of Owl Insights, and more importantly, I'm joined by Monique Lucas, who's Vice President of Integrative Care at Monarch, a leading community mental health group located headquartered in North Carolina. Monique specifically is an expert in delivering whole person-centered care. This organization has received substantial funding from SAMHSA to provide their services, and Monarch specifically is focused on addressing mental health and behavioral health issues. Primary care health screening, expanded access to veterans, and collaboration among community partners. I think it's safe to say what they've accomplished is really cutting edge or leading edge, and we're going to learn a lot more about that on today's conversation. So with that as a backdrop, just would briefly want to talk about who is Owl Insights and why, what we do to support community mental health organizations. Our focus from a overall strategic aspect is on helping enable precision-guided behavioral health. Our goal is to assist health systems and behavioral health organizations expand access, improve quality care delivery, provide clinical decision support, and help organizations better manage costs and support value-based care initiatives. The way we go about that is through a measurement-based care platform that enables providers to easily screen, track, analyze, and guide treatment using patient-reported outcome measures, often referred to as PROM, as well as capturing social determinants of health for risk stratification. And really the end game is to make sure that we can enable our customers, community mental health organizations, and health systems have greater enhanced clinical confidence. Next slide, please. So today's conversation really is talking about the delivery of behavioral health services in a community setting, and really understand the differences that may exist in that environment versus traditional healthcare ecosystem. Secondarily, what innovations are afoot by leading organizations such as Monarch, what type of collaborations exist in the community around supporting hospital to home in a post-pandemic world, and lastly, substance use disorder and some of the challenges of coordinating care for those patients afflicted with these conditions. So as a backdrop, I thought I would try and provide a little bit of context around some acronyms, the first being CMHCs, which stands for Community Mental Health Centers. These are typically facilities offering a comprehensive array of community-based mental and behavioral health services, and it spans typically everything from inpatient care to outpatient, as well as services often referred to as partial hospitalization, intensive outpatient. It may also be involved in supporting emergency care. Now, a subset of those have received federal funding from groups such as SAMHSA, and therefore are achieving the designation of CCBHC, which stands for Certified Community Behavioral Health Clinic. Again, Monarch being one of those beneficiaries. And there are specifically requirements that are to achieve this designation. It would provide a whole array of services, which we'll get into very shortly. Next slide, please. So this is something that is, I think, worth of taking notice, and kind of the results to really validate that those community organizations that have received funding and have been designated CCBHC, the type of results they're achieving is really worth noting. Everything from standpoint of improving patient access, decreasing patient wait time, follow-up often is expedited, coordinating care across the community is often achieved with tremendous success, and then follow-up. I would just say from an overall vantage point, just some quick, what I call credibility points here is CCBHC patients report a 62% reduction in both hospital and ED visits. You often see them getting back to work at an increased rate, and overall returning to more normal lifestyles. They're expanding. In fact, the current administration is providing additional funding to support an expansion of CCBHC designation and supportive services. Now with that, I think another point of consideration is there are additional requirements to achieve this, and it's often related to quality reporting, governance and staffing. But in exchange for meeting these criteria, they often qualify for a Medicaid payment rate that covers the real costs of delivering enhanced services to an increased number of patients, and really helps transform a number of these community mental health clinics in expanding their services. I think in summary, there's kind of 4 key points to highlight. Number 1 is expanded access to care through enhanced workforce. There's often been a stronger response to battling the addiction crisis, and patient access and patient outreach is often enhanced. So with that as a backdrop, we are big proponents, and this is an important part of the behavioral health market that needs attention and will benefit from additional technologies such as the OWL. Next slide, please. Okay, I'd like to really ask Monique to really expound upon kind of what do you see as some of the details, how this model of CCBHC differs from traditional care delivery models. And Monique, can you kind of enlighten the audience on some of the distinctions that kind of warrant consideration and conversation?
Sure, Eric. So I think you touched on a lot of really good points. And the key point being, these enhanced wraparound services that are being offered through these new advanced models are typically not services that we are compensated for. So when we look at our model of care, we are providing patients with wraparound enhanced services, targeted case managers to help support them with barriers that they may have with social determinants of health. But in our real world today, none of those services are covered. So while we may want to deliver care in that manner, we really can't. And what we found is that by having these additional services and being able to provide whole person care, wraparound care, coordinated care in a thoughtful manner, we've really been able to drive the outcomes and the engagement of our patients.
And what type of evidence-based practices ideally are part of this offering? Or what do you see as kind of critical from an evidence-based approach?
Yeah, absolutely. So we are looking at treating co-occurrent substance and behavioral health abuses together. So no longer looking at medication management for substance abuse and medication management for behavioral health in 2 different capacities. Also looking at incorporating therapy that is going to look at the patient's whole picture as well. We are using a lot of evidence-based screeners to help us identify patients with need and help guide us with our treatment plans. And definitely looking at, using different techniques like motivational interviewing, so that we can help get to what it is that the patients actually need help with versus us impeding what we think they need.
That's interesting. And can you kind of speak to some of the distinctions that you see in this environment relative to a traditional health system?
Yeah. So in a traditional health system, you come in and you're treated. So you see your doctor, you're prescribed your medication, and you're sent home. Typically, you have a follow-up visit with that provider, possibly some therapy that's included, but that care is not necessarily coordinated or connected. With our model, not only are you going to see your physician, but we're going to assess you for different needs that you could have and connect you with additional community resources. So if you need support with finding a job, we have an employment program. If you have barriers with social determinants of health, you don't have food, you can't afford housing, those kinds of things, we connect with our targeted case managers. For our people who just need somebody to kind of relate with them and keep them going along the line, we've got peer supports. And then we also have an additional interesting component of a family partner to support parents who have children who are going through transitions and stages between behavioral health and substance abuse as well. All of these are things that can be offered in a mental health clinic, but we don't necessarily always have the means to fund these types of services to support the patients who actually have the need.
This makes a lot of sense. I mean, whole person care, and you're saying even extend it to the family. Are I'd be curious on how you're kind of documenting your success, whether it's through quality measures or other means, to show that this model is really is effective. And
Yeah.
what steps have you all taken at Monarch, or what have you seen from your peers to really show that this is, at least in your environment, the right way to deliver care?
Absolutely. So with Monarch and actually CCBHCs as a whole, we have been given 9 CCBHC required measures, and those measures are pretty closely aligned with some of the MIPS measures that the rest of our agency are looking at. So we have really put a focus on building and developing those dashboards so that we could visualize, how we are progressing. Some of the metrics that we're looking at looks at time to treatment. So initial time for initial referral to actually being treated with a comprehensive assessment. We're looking at smoking cessation. We're looking at support for patients with BMI. We're looking at folks with depression remission after 12 months. We are looking at folks who are provided brief counseling if they serve positive for an alcohol screening. So we are doing a lot of the data collection to kind of see how this is impacting. And at Monarch, we have the ability to look at how we're functioning as a CCBHC in comparison to the other 13 outpatient locations that don't have these additional wraparound services.
And maybe just, I was probably speeding here a bit, but can you just take a step back and just briefly talk about your organization, how many locations does you all provide, where you're located, and just kind of your patient mix?
Absolutely. So Monarch is a very complex behavioral health agency. We have outpatient facilities that offer therapy as well as medication management. In addition, we also have long-term care services, so multiple group homes. We've got a youth crisis center. We do have a behavioral health urgent care unit up in the Wake area. We span across North Carolina, so we serve about 28 to 30,000 patients annually across all of the counties in North Carolina.
Great. And how many physical locations do you all have?
We've got 14 physical outpatient locations.
Okay.
And right now, our CCBHC model is in one of those locations.
Okay. So when you look at the sheer patient volume, you're one of the biggest, obviously, I would imagine, in the state, if not the Southeast. And it's interesting to compare your volume with sort of traditional health systems, which arguably some behavioral health departments actually see far fewer patients than what you all really see on an annual basis. I think for those not intimate with the community mental health setting, don't realize just the volume of patients that are receiving behavioral health services in a community mental health environment. I think the government understands with the funding. So you mentioned that one of your 14 locations has achieved a CCBHC designation. Is there plans to expand and have that designation be for other locations within the Monarch environment?
Absolutely. So the work that we've done in the CCBHC, we've actually been able to build and identify good workflows and operations that we can scale throughout the rest of our agency. So while the rest of our agency isn't 100% compliant and certified as CCBHCs, we are rolling out different initiatives such as our medication assistant treatment program, which started in our CCBHC, and we're looking now to expand that across 5 counties. We did a pilot with a patient ping program where we were looking at patient hospitalizations and getting real-time notifications. We were able to stabilize that workflow in our CCBHC, and we're now scaling that across our agency as well. We are hoping that we will have some additional funding opportunities to continue growing our CCBHC, and if so, the plan for Monarch is to scale and have more locations under that certification as we continue to move forward. We definitely have worked through a lot of the kinks, and we think we have got kind of the secret sauce us to have this going well. So we are at a point where we feel like it would be beneficial to scale it to as many of our locations as funding will allow.
But I'm assuming it's public information. The amount of money you all receive as part of this, is this doled out annually, semi-annually, and kind of what's the size of the type of funding that you all receive with this designation?
Yeah, so we actually had 2 grants. Our most recent one was $3.9 million, and that was distributed over a 2-year period.
It's very assuring to see that the government provide supportive grant funding so you all can deliver on the services. From in our company, we track progress through kind of a key performance indice or a KPI dashboard. I'd be curious on what type of metrics you guys use to see that things are going to plan, or if not, take some course correction to improve your business processes or clinical services. So are there any key metrics you lean upon to see if things are going well?
Well, so I will tell you, with the CCBHC model, we've got multiple programs that need multiple KPIs to keep an eye on. If we look at our MAT program alone, we've got to have checks and balances to ensure that that program is functioning, in fidelity to the model that was built. So we have got KPIs for each of our programs that are aligned with, the set outcomes that we've kind of put in place for those programs, in addition to our general CCBHC goals and expectations. So, for example, we are looking at, number of days in the program, reasons for discharge. We are evaluating length of time in our programs. We're looking to see our actual engagement rate in these programs. So are patients actually working with the resources that we're providing to them, or are we just putting resources out in the community? We're looking a lot at treatment planning, so looking at our treatment plan goals and seeing how many of those goals are being resolved, how long is it taking for those goals to be resolved, and how many different individuals from the care teams did we have engaged with that individual. So definitely looking at a lot of different data points across the multiple programs that are required for us to be a CCBHC.
That's great. And how much of these metrics are self-defined versus a requirement as part of the funding?
Yep. So we've got the 9 measures that are required as part of the funding. All of the rest is stuff that we are driving to identify, what populations we need to focus on, identify where we may need to create clinical pathways, and really evaluate what services from the CCBHC model are really sustainable business models for us to continue out and scale throughout our agency.
If you talked about your organization and the number of patients you see, is there anything specific around the type of patients seeking your services that may be unique to a health system?
No, I think our patients are just like the same average patient that anybody's seeing at this point in time. But what I can say is the dynamics of the patients are changing. Since we've seen COVID, it's a lot more people being impacted by behavioral health. And I want to say maybe the stigma is going away somewhat because more folks are reaching out for help than we've ever seen before. So I'm seeing a lot more people who you wouldn't classify or consider as a behavioral health patient now coming to behavioral health for help. So that is a little bit of a change in the dynamic of our population.
Yeah, I think that's important to see a destigmatization going on here.
Mm-hmm.
Are you seeing with the onset of COVID and just trying to, as we go forward and live through a post-pandemic environment, are you seeing any positive signs such as retention rate or no-show rates reducing?
So I don't know that we've seen a whole bunch of retention increasing, but we have had a lot of new folks coming in the door. So more folks are asking for help. As far as follow through with help, it's still kind of the same song and dance. They come in, they want help, and then it's very difficult to follow through. Now, where we have the upper hand to other agencies is we've got teams out in the community that we can launch to try and re-engage these folks. So when we do have no-shows, when we do have folks that fall off the map and we don't know what's going on, we've got a team of case managers that we can have, reach out to those patients, try to engage them and ensure that they're okay so that we don't drop the ball with those patients.
So, I'm super interested, just given how nimble organizations like yourselves are in responding to situations, environments, needs. I'd be delighted to hear some of the programs that you have seen implemented within Monarch or among your peers that you find interesting.
So one of the coolest things I think that we have done at Monarch to date is our partnership with Patient Ping. So in North Carolina, we had some disruption with getting our ADT feeds. So we were not getting any information on our patients, their hospitalization status, but even though we weren't getting that information, we were still being held to the expectation of 7-day patient follow-up. So our partnership with Patient Ping really opened up a new door for us to be able to know where our patients were in real time so that we could react and respond and get those patients back into care in their time of need while they were through transition. So this software that we use with Patient Ping sends real-time alerts to our care managers, our therapists, our physicians. They get emails directly when one of their patients is in a hospital, urgent care, or skilled nursing facility. And then we also have a peer who is located in the hospital, which we've been able to identify had the most volume of patient emergency room visits. And we're able to follow up with those patients in the emergency room as well as inpatient follow-up. We've launched a nurse care manager who works closely with any patient who has an inpatient stay to make sure that we have a consistent 90-day follow-up for care for all of those patients that are discharged out of the hospital as well. So this has definitely taken us to the next level to allow us that ability to be able to coordinate care with our community hospitals to make sure that our patients are not falling through cracks.
That makes complete sense. When I hear you talk, there's such a practicality and yet on what you're doing, to make sure that no one gets left behind. On this Patient Ping program, I'd be curious, how do you know that the patient's at need right now? Do they send a text? Is this responding to something like a response to a self-reported outcome like the Columbia? What exactly is being captured there that allows you guys to escalate in a very expeditious fashion?
Absolutely. So we get a notification anytime the patient walks through the door. So as soon as the patient walks through the door of an emergency room, we get a notification that the patient has been in that facility. So real time, we know that that patient's in that facility. We can watch that patient to see when they go through their process with the hospital. So we are notified the location that they are at. And typically we have relationships built with the different discharge planners in the different facilities that we work with. So we reach out to them immediately and we can start planning discharge at admission instead of waiting until that discharge period kind of happens. If that patient does get admitted into an inpatient or an observation stage, that event also gets documented in Patient Ping. So we would see them move from emergency room to observation or inpatient, and then we'll also get a notification when they're actually discharged. So we are really getting real-time alerts of when our patients are at the hospital. Now, do we know the reason for hospitalization? Not always. And that's kind of one of the blind spots that we have to our workflow. But we at least can identify a population that potentially could have a need, and we can reach out to them and find out if they need that support.
Let me ask you a question along the lines of innovation from a service line. Given that COVID really, in some ways, ultimately expedited the use of telehealth or virtual care services, I'd be curious on how you looked at your existing service lines and how that may have evolved in response to the pandemic. So can you talk about some of what COVID enabled and forced you all to do at Monarch?
Yeah, and actually, to be honest with you, interestingly enough, I feel like being a CCBHC helped us to prepare better for COVID. So we were already kind of using a virtual open access model with patients. So we were making sure that our patients were being seen the same day, if not the next day when they were coming in for care. So really, we were already kind of set up for success in that factor. We also had community teams that were launched and already connected with a lot of our community resources. So as we were identifying new folks who now had determinants of social health that had never had them before, we were able to quickly respond and get those folks connected to the resources that they needed. We knew about all of the food giveaways. We were able to communicate that to patients in need. We were able to connect patients with filing for unemployment, which was a big task for us throughout the last few months, just trying to get people back on track. And then the fact that we had people that already had these relationships with folks in the community. A lot of our case managers were just doing a lot of wellness checks with people, talking them through, talking to them about, the protecting themselves and making sure that they had masks. We were giving masks out in the community when needed and giving folks sanitizers if needed, to try and educate folks as best we could and keep down some of the anxiety. It's such an untelling time.
And I'm curious on how much of your care, over the last 12 months did transition or is being delivered in a virtual care environment right now?
Today, we are pretty much 95% virtual. Our therapists are primarily working from home. We use a few different telehealth platforms to communicate with our clients. We do have capacity in our office to have folks come in if they don't have technology to support a telehealth visit. But even if they come into the office, they're in an office with a screen and the provider is in a different location, in a different office, just to keep precautions. We have started to discuss getting closer to opening back up and getting things back to normal now that we've got more vaccinations out there and folks are getting a little bit more comfortable. But I will tell you, I think this operational change is going to impact us for the long term. I don't think we will ever go back to brick and mortar everyday appointments in the office. I think our model is going to transition and it's going to be some type of a hybrid model from here moving out.
These KPI dashboards you mentioned, I imagine, are key in ensuring that virtual care is at the same level as you were delivering beforehand. Let's talk on the next slide about some of the collaborations. I think you've already touched upon that, and the tight linkage you have in the health system community. Has that changed much in the last year, or as you look forward, or the type of collaborations you're envisioning with providers, payers, or even the patients themselves?
So with CCBHC, collaboration and community partnership is really a big initiative. And I will tell you that this grant has really allowed us to spread our wings and form some really good partnerships with some folks in our community. One of the innovative partnerships that we have is with our EMS team. So Stanley County EMS recently got a grant that provided them funding to be able to deliver Suboxone out in the field. So Suboxone is the medication that we administer for our MAT clinic. So opioid folks that have dependence, when they go out and they have an overdose, our paramedic team would go out and they would reverse that overdose. And then they would give them the opportunity, if they wanted to change their life and start on a program, they could do it at that point in time. The way our partnership worked was we provided a peer support to work with that paramedic team. The paramedic and the peer would go out on all of the calls. And once that patient was reversed, they now had somebody who understood where they were coming from, could connect with them and help to transition them to whatever level of care they were ready to receive at that point in time. Our peer has taken folks to inpatient facilities, admitted folks into our MAT program at Monarch, sometimes just kept in touch with folks for months on end until they were ready to receive treatment. And we actually had some really great outcomes and stories from the work that he was able to do with our EMS team.
As you look at kind of 2021, 2022, are there additional initiatives that you all plan to undertake?
We just started a brand new collaboration with a federally qualified healthcare agency named Goshen. So Goshen is actually providing a mobile health unit outside of our behavioral health clinic to provide primary care services 3 days a week to the uninsured and underinsured population. They have walk-in appointments. We've got a nurse practitioner. They've got a team, and they've actually got a pretty neat mobile unit set up with 2 exam rooms, a lab, refrigerator, sink, anything that you could imagine in a doctor's office. They've got EKG machines. They've got it all in there where they're able to provide primary care. So now we're able to refer directly to them if we need labs drawn, if we need any follow-up care. So we're very excited about this new collaboration. An additional collaboration that we're working on is with our Department of Health to help educate folks, or physicians specifically, primary care physicians, about behavioral health screenings, and referrals to different levels of care. So we're very excited about the collaborations we have coming up.
Well, I'm hearing loud and clear, it's whole person care and also really a community mindset. Next item, which I think we've already touched upon, which is the really of, how do you coordinate care for those with substance use disorder and co-occurring mental health issues? That's the harder problem to solve, I would imagine, when you've got these type of comorbidities. But
it is. But I will tell you, with our substance abuse population, so we started off with our MAT program, and after serving over 98 patients in the last 2 years, we've decided that we wanted to expand upon that. So this year, as part of our newer grant initiative, we have launched an intensive outpatient substance abuse program to kind of support some of those folks in our MAT program as well. Obviously it's going to be the golden stamp of approval for folks to have medication management along with intensive therapy if they're falling within that realm. So with that, we've definitely been expanding upon those services. Additionally, with our MAT program, we have interwound the use of a targeted case manager to work with that population. We realize that it's difficult for our physicians to follow up with that in-between care. So in order to make our model a little bit more comprehensive, we've got a case manager involved to help give that patient kind of a little bit of hand-holding and guidance and support towards those goals that they have set.
Are these services co-located physically? So,
yep.
Okay.
Yep. Actually, our MAT team meets as a team: physician, our medical assistants, our case manager, peer support, and therapists. We have daily huddles where they meet to discuss patient care on a daily basis.
Okay, great. I think we've just got one more slide here just to kind of wrap it up and bring it home. Tried to capture what we believe, and I think this echoes some of as you've outlined, the requirements to be a beneficiary or receive CCBHC funding. From a standpoint, there's a certain number of measures that you're required to report upon. From an evidence-based practice, provide 9 types of services. As you look at, we've talked about access to care, and it seems like some of the benefits I think you've attested to is decreased wait time. There's requirements around MAT. And, as we look at really serving this market for organizations such as yourselves and your peers, that we believe this is a good fit for having a measurement-based care platform that can provide supportive prompts as well as analytics, social determinants of health, and be able to support really whole person care. So I think in closing, first of all, thank you for the work that you and Monarch do. Obviously, the community is benefiting from that. And I hope this has also given a highlight to the audience of what a key segment of the market in addressing the behavioral health crisis that we're all faced with. Lastly, I would just summarize what I've heard from you is that you all have taken a much more comprehensive view on providing care to the patient. It sounds like there's a lot of collaboration that goes on with your peers within the health system, such as being able to know when patients show up at the ED, and also just really being there for the patients, as needed, and really providing a true on-demand service. So we believe as a company, this is an important piece of the healthcare system and really a chance to really lead the market in addressing this crisis that we're all dealing with. So we're lucky to have you all in doing this. And Monique, just want to thank you for your time.
Thank you. Thank you all.